Have you ever wondered how you would need to tackle the difficult situation when you have so many models and you don't really know why they might contradict each other? Well, for the following half an hour, we might help understand these points a little better. So first of all, like for any models, you need to know that people have perspectives and see things differently. So my own perspective might bias the way I present you the topic. So I'm going to give you a few clues about who I am so you understand how this might influence the way I talk to you about models in healthcare. So I'm an independent clinician, I'm an osteopath, I work in my office. I've had quite a bit of experience in community health and research. I've put up projects, I've worked as a full professor in an applied university, and I've received funds in different research. I'm very, very motivated to promote research and critical thinking in practice. I am an editor at the iJom and also at Main Libre. I also work at the Board of Trustee of COME. So, what are we going to see? Well, I think first of all for models, we have first to try and define them and see what do we mean by models, and then to see how context might influence the way models might be applicable or not. And then we're going to see how we evaluate these models, and finally, but how can we implement different changes to have a better view and vision of how models might help us in our education and also our practice. So let's get this started. Well, defining models. Models, we can think of this term being used quite broadly. So what can we have? Well, the first model we can think of is a role model. So someone we might look up onto and use as an example, and it might dictate our behavior and how we manage things. So this is an inspiring model. We might have a simulation model. So this is a model that aims to imitate the real world with scenarios and practice. So we minimize the risk and let us practice some things. So this is imitating the world. Then we might have physical models. So this is a reduction of the real world. It's a scaled representation of an object. It can be a model plane, a model train, planetarium, maps, or anatomical structures. So this is scaling things down. Then we might have organizational and educational models. These structure our approach or framework, and they describe systems and the role and its components to achieve sets of objectives that we might have. So these structure objective. And then we have theoretical and conceptual models. These give us the framework that serves to guide the structure and provide foundation for understanding phenomenons and links within its components. These are harder often to grasp because they're often abstract, conceptual, and they explain things. They're focused on ideas and frameworks that might be based on philosophy, logic, or qualitative analysis. And all these elements make it that these models might sometimes contradict each other. These are really quite broad in osteopathy and other disciplines such as psychology, and we'll see these a bit deeper, a bit more later on. And then we have these, so they're meant to build frameworks. And then we have scientific models, so they're empirical, testable, and predictable, and they're built on data to simulate and explain real-world phenomena and quantitatively. So sometimes we have theories and conceptual models, and they're validated through scientific models because we can collect the data, and sometimes methods make it difficult to do so. So we see that there are lots of different definitions around the world of word model, and what do they have in common? Well, they're all not the real thing. We can all admit that the model is a representation of something. It's not the real thing. So here, for example, we have, I think it's a map of the middle of Milan, and the map of the middle of Milan is not the real sight scene as we can see on the picture, and that sight scene is not the real Milan because it still is a picture. So models are representations. The other thing is often a model tries to simplify things. So we try and bring things down to a simpler version for us to understand its links to other components. And by simplifying, well, we're missing out on some information. So for example, if we take the shape on the right and we do 3 projections, well, once we'll have a square, triangle, and a circle. And these are proper representation of projections. And even if people might not agree with what shapes they are, there's still proper representation and simplification of the object on the right. Models can be more or less accurate depending on what we need. If we need to play a Pictionary game, well, we might not try and draw the right drawing of the precise dog because we don't have the time, and the one wall on the left will do. But they can be more or less accurate. And they're more or less valid, meaning of depending what we're using for, the representation can be a proper representation of what we do or not. A plain representation of our world is very useful on a map on a small scale to be able to move around, but if we have to plan flight courses or even navigation, it might be a bit more difficult because suddenly we have to consider that the projection is flat and not round, and there a globe might be a bit easier to be able to see what the shortest path is to getting from one point to another. But the globe might not be ideal to be able to understand our position within our solar system, or even a broader perspective, to have something that gives us a sense of scale, and then we don't see any details anymore. So it's more or less valid, sometimes on purpose, for us to be able to represent things and see things, but we must never keep in mind that these things are not necessarily what is observable in the real world. Why do we use models? So let's just focus a bit in healthcare, and usually, well, models in healthcare offer a structured way to simplify, interpret, and manage the complexity of health and illness, and it helps patients, practitioners, researchers, and policymakers make evidence-based, patient-centered decisions. So we're really focusing and trying to help us move in all that complexity. So some models might be there to explain health and diseases. Others might be to develop and evaluate interventions, such as research designs and so on. They can also help us guide clinical decision making, like clinical prediction rules. They can also manage health systems. And also they can help education and have us a better understanding of how things, our knowledge builds up and articulates together. So let's go through a few of these to give some examples so that you have a better feeling of what are all these models. So I'm picking these because they're quite illustrative. There's loads of them, so they're just examples. But let's first see the Framingham risk score. The Framingham risk score was a score developed from Framingham. Framingham is the largest cardiovascular cohort. It has 15,000 participants, and it started over 75 years ago in Framingham, which is a small city in Massachusetts in the USA. And so there was extensive physical examination and lifestyle interviews. And the aim of this study was to model cardiovascular risk factors and target treatment for people who were at risk. And it made it possible to create these lovely predictive rules where we can measure scores and risks for individual depending on factors that were noticed within that population at Framingham and for those who developed cardiovascular diseases. And these models are used today to know whether or not what type of treatment we're going to initiate and whether or not we're going to give these treatments to patients, if it's worthwhile or not. So this is in preventive care for preventing cardiovascular diseases. Another example is the Ottawa ankle rule. So this is a predictive clinical rule. And the aim is to try and spare some time and money and try and rule out different conditions without going through further exams such as x-rays. And the idea was, how do we do clinical examinations to rule out fractures within the ankle and foot? So they developed the Ottawa ankle rule, which is 3 different points where we squeeze, touch, and so on, and whether it's pain, whether the patient could put also weight, I think, on their heel, and so on. And they found it had 100% sensitivity and 40.1 specificity to detect molar fracture, and when using it, it reduces 30% of ankle radiography in emergency departments. So really a way to not diminish the quality of care, but really spare money and time for everyone, and a bit of radiation. Then we can go into psychological models that predict and explain processes and change. So this can be explained changes in grief, so different processes. contemplation, pre-contemplation, action, maintenance, termination, and pre-contemplation. But it was used to be able to address addiction and also resistance to exercise. And it led in medicine to do motivational interviews and to just find out where people were in this cycle, and then to change the types of intervention and address them depending of the state the person was and their own feeling towards their addiction or lack of exercise or difficult in compliance with anything. So actually we can see that initially it was a psychological model, but it quite quickly came up as a model to be able to manage patients and help them bring change when they want to. If we look for physical activities and see what happens if you do motivational interviews, we can see some really good effects in improving people's compliance and continue to in doing physical activities. So not only is it a sensible model to understand and explore, but after when we put it in application, it actually does help. It works. Another model that we can think of is cost effectiveness of model. So this is more like an economical model. It's for public health positions and whether or not we will favour certain exams or material interventions. And it's always between the costs and the gain we have from that. Usually we use QALYs, which is quality of life, and we see how much it costs to increase different QALYs. These analyses take many factors into consideration, and then we can see how much it will cost or how much can we spare by removing or adding different components of care. One example of a cost effectiveness was done during the BEAM trial, where we tried to combine different treatments, either only just best care with a GP, and then we had them see some physical therapists, which were either osteopaths or physios, and they were given either exercise, manipulation, or both. And we could see how much were gained in quality of life and how much it costs, and find the optimal both intervention, and it was the combination of manipulation followed by exercise, the M and E, which gave the best curve in sense of cost effectiveness. Another model is like a clinical pathway. This is an example from the NHS, which is the clinical pathway for low back pain and radical pain management in the UK. These can be specific to each health system, and it just shows how patients might flow from one system to another, from one place to another, and how this works. Then we have approaches to understanding what are we addressing and how do we consider the health within patients or people or the entire population. So the salutogenesis model is a model where rather than considering the underlying pathology, we consider what are the person's resources to be able to tackle sufferance and the conditions they have. So to explore their resilience and increase their resilience, but also see what resources they have and in what system they are as a coherent factor. So also taking account what they do, what they want, and so on. And it's a very broad way of seeing health and being able to use resources and adapt treatments to people's circumstances. And we can see if we adapt this model, we might not have exactly the same allocation of resources than if we use a more pathogenesis model. But both are completely compatible one with another, and it's not because we have a salutogenesis model that we will not address specific diseases and their causes. Here's an educational model. So this one was developed in Canada in the 90s, and it was deciding that we wanted to create the programs based on the skills that we required at the end. It was so successful, it was adopted by most developed countries, and these are the ones that are adopted in Switzerland, in the UK, I think in France, Germany, and so on. So we see initially that it was a model of saying, well, how do we construct a program? And this one is widely used in health. There we go, the different types of model. So what we see is once we've done that model on the competencies, things change afterwards because we've decided that skills were based on these skills, on those competencies, and therefore that we had to base continuing professional development on these different skills. So the GOC in the UK has asked people to build up plans and strategies to be able to make sure that they maintain these skills at all these different levels. So that's it for the first section. Let's tackle the second, which is more on the notion of contextualization. So first of all, let's address historical and socio and cultural contexts. So as we know, models will be developed for us to understand and help us also as an instrument, but these might not be as useful depending of where we are, how we use them, and we're going to see a few of these. So first of all, the historical context. So when was a model done? And so what did we know at that time? And how is the health system functioning? To give a small example, if we use Still's model of his vision against vaccines, well, if we look at the timeline, he elaborated his osteopathic principles in 1874. The attenuated vaccination, which was invented by Pasteur, which started making that vaccination didn't really kill about a third of the people who received the active germ at the time, was in 1885. So it was 11 years afterwards, which means when Still is talking about this, he's talking about vaccines as they were seen at that time and not right now. Furthermore, we might say, osteopathic care might address certain conditions because medicine isn't able to do so in the model in 1874. But if we look further up, antibiotics were discovered by Flemings only in 1928. If we look a bit back, the germ theory is in 1861. So this is 13 years before Still and his principles. Didn't even know that germs existed. We found out that using disinfectant surgery would avoid consequences only in 1846. So all this has to be put into context when we're using models, especially those developed in the past. Secondly, the cultural context will really define how our model is used and useful, and some of these things might make models inappropriate or difficult to put into application. So we have elements like beliefs, but also the practice, how we do things, the values that people have, tradition and customs, roles and relationships between people, and behavior and actions. And all these need to be accounted for. Also, the political context might change our health environment and how spending and priorities are set up. And so these need to be accounted for as well as they change over time, but also that sometimes they open opportunities for change and improvement, and sometimes they might be focused on other priorities, and there's no use of actually pushing certain models forwards or not at certain time points. Political determinants of health model gives a few insights on what are the elements that could play a role, and how health domain needs links with political ones to be able to also to have common understanding of what is required and how things need to move forward. The economical context is equally important because we have limited means, and these have to be mobilized at different places, and finding out where it is and how it works also defines how our models might be applicable. So there we can see in different health systems the role of the patients, the role of the provider, the impact of risks and insurance, and all these different elements could play a role. Another large contextual factor is the philosophical standpoint we're taking within a model. So what are we mentioning? And I really like using Saunders' research onion, which is a very good illustration of different perspective we can take either within research but also addressing a model and how is it constructed. With the outer layer that's really related to the philosophical position we're taking, with positivism on one side and pragmatism on the other. And whether after we're using, what type of reasoning we're using, deduction, adduction, induction, and so on, and different types of research that goes from qualitative research and observation to more quantitative and experimental designs that can be used. And then we can see which research designs support our vision and our models, and that are used depending on the philosophical standpoint and so on until the data collection and the time points, whether it's following through time or just a cross-sectional view or so on. Now, the philosophical standpoint is more of how do we think that knowledge is built and how does our model relate to reality? And I think this is a really important point of view, and as long as if we have an instrumental point of view, all models might have their flaws and their strength and limitation. And I think this is an interesting point of view to be able to use these models. And finally, the context of scientific paradigms, existing controversies, and interdisciplinary insights. These are also really important because they will give us a feeling of how does our model fit in, and how will I be able to use it without having some form of difficulties or opposition when using it. So the scientific paradigms is whether or not the context and what we know in the present day makes it possible to assess and support the model or not. The existing controversies is whether or not the model has some form of controversies. People don't agree with some underlying principles or important components within the models. And the interdisciplinary insights is the fact that the model has been seen by people with different views on, and different knowledges about our world, and that they have been able to give controversies or limitations of the model with that insight. So let's get to this third section, which is how do we evaluate models? So how do we know whether a model is fit or not, which can be related to the circumstances or the context that we've just seen. There's certain points that we might need to check to make sure that our model suits our needs, but also to be able to recognize their limitations, sometimes in communications, and some flaws that the models might bring when we're using them in our daily practice. So quality of models can be assessed in different ways, and each expectations might be met or not. And the importance is to know just what value these has, and it depends also what the model is made for and how and why we're using it. So the first point that we're trying to qualify within a model, it's its explanation ability. Does it truly explain things? Does it actually provide additional information onto understanding how things build up? And does it have value in explanation? Or on the other hand, or in addition, does it have any predictability value? So does it help me be able to know what's going to happen in the future? So take decisions to avoid different things, or know what to do at the time when I'm using it. So that's its predictability. It has to be consistent with existing knowledge. So does it give me a view and a framework that seems compatible with other things I know, or does it enter into conflicting knowledges, which can be a bit annoying? The practical utility is a really important quality of a model. Is it useful? Does it take too long to use? Is it too complicated? Is it hard to understand? And so on. These different points are really important. Simplicity and parsimony. So the simplicity is it's not overburdened, so it goes straight to the point and it uses only components that are really useful to understanding the model and what it's made for. And parsimony is that there aren't too many models, so I don't need 100 different versions of a model to be able to do something. They need to be quite restricted to the field where they're most practical for. So no use developing a new model in one when there's already loads out there that have been used and been already tested and validated. One point that's really important for all models, it's their falsifiability. So that means, can I show whether or not it's wrong? In one way is, how do I actually abandon a model once I've started using it? And that is also because I know that sometimes we can show to what extent it's wrong or unpractical. The falsifiability is something that we can always assume from a model because it's not 100% realistic. But the falsifiability is to show that actually the model does not help us do what it's intended to do. It doesn't work in the sense it's been built for. And that's really what we're aiming for. The generalizability is whether or not my model has been shown to be useful in really different contexts, cultural, population, and circumstances, or whether it's really just targeted at one place or another. And that adaptability is whether or not the model can be improved in time, where it has room for improvement if we see that it can be. So that's the different expectations from a model that can be done for any of them, and it's worthwhile just to go through these points to be able to see what are the strengths and weaknesses from a model that you're using. And then we have the level of evidence of the model. So this is a Coma collaboration evidence scale. And this is a way of knowing to what point have we data to support the model. So how strong is the model? So models are, of course, just representation of reality. So they're not totally in 100%. But we can have models that are more or less appropriate. We can have like wrong models, which will give false explanations or have low to no predictive ability whatsoever. And so there's this grading system with marking ranging from A to F, depending of what has the model gone through. Has it gone through the test of falsifiability, and has it passed these tests, and is it supporting our beliefs? So the strongest is a generalized theory, which means that we have loads of different experiences that have been going around the model, which have supported the model over and over again in different time frames, different cultures, different societies, and so on. So an example of a generalized theory is, for example, the germ theory, where it's been proven over and over again. Level B is explanatory theory, so that means that we've had supporting research that give us a clear vision that our theory has underlying support, but it's not wide enough for it to be generalized. C, model with empirical support, probably 1 or 2 small studies that support the model, not enough for us to be sure that that's the best way of going through, but still some data that supports the model. D, model with expert consensus alone, so people agree that the model seems to fit what we see in daily practice, and then we have expert consensus. E, it's an untested hypothetical model without broad consensus, meaning there's some contestations and some people contest the model as being appropriate or representing something that's useful or in the decision process that it takes. It can also be that the model leads to false beliefs that that are risky for patients, or also that might lead to waste of resources in learning useless stuff, principles or components, or wasting time doing things that don't bring any additional values to patients or to the healthcare system. And F is an existing evidence against the model. So if we have proof that a model doesn't work, well, it needs to be changed usually. And usually in practice, we use models ranging from E to A, and usually F we should avoid, or at least change them. And that's for the level of evidence for models. So how do we implement this in our day-to-day life? Well, one thing is really important to understand is that for models to have any kind of meaning, we need to have close interactions between the real world and practice, and then the world that tries to understand it and help us model it and predict and so on. So between research and practice. And here I've shown you 3 different principles that underline the importance of these interactions. The first one is the notion of knowledge mobilization, where we have exchanges and different elements that create a link between people investigating models or creating the models and those using them and so on. And that it's a cycle of development of knowledge. Nothing is set in time and it just moves forwards. The second is the use of qualitative research within fields, which really makes it possible to go and explore people's experience, and that draws knowledge also from their doing and their seeing. That then can be transformed into hypothesis and can be tested again, even with quantitative research. But we really see that element is fundamental into exploring. And then there's the notion of practitioner-based research networks that make it possible to bring in data. So I put the NCORE one, there's a few others. The COMA also has some form of links between researchers and practitioners and informing, and it's going both ways. exploring what people want, need, and then also informing patients, simplifying research results and communicating it back. And then also we need to understand that if we want to develop models and for them to be as appropriate as possible, it requires a whole set of skills. So we have human sciences, physics, chemistry, maths, statistics, engineering, methodology, critical thinking, logical reasoning, and research integrity, and all these come together and might contribute to making models as fit as possible. And sometimes, and most often, all these skills can't fit into one single person. And so it's really worthwhile working as groups and in teams, and being as also interdisciplinary as possible to be able to work and reflect on these models and then bring forward some models that make sense to everyone. That makes it also possible for models to overreach one discipline and really inform everyone on how our world works and how these models can help us move forwards. Finally, well, the culture of research and the notion of models and the fact that these need to be improved and tested is part of research culture. And we see that there are many different levels where this can work and where we can have influence for models to be improved and for both education, health system, education system, professional organization, practitioners, patients, all these different levels to be able to understand how important it is to improve and embed the notion of research to make that possible. So there we see at a system level, at an organization level, or at an individual level. So, what can we remember from all this? So, well, there's always room for improvement, so models can always be improved either by simplifying them or adding things to them or adapting them, so always room for improvement. Second take-home message is having a plurality of models is really something rich. So having diversity and disagreement only shows that knowledge needs to fill in some gaps, and this is quite normal, and so agreeing to disagree is probably a good solution for people to try and understand discrepancies between models. And finally, the reflective approach of models is really important. So to have an in-depth vision of what models are, what their strengths and limitations are, is probably the best way of using them appropriately. So thank you very much for your attention, and I hope this has helped, and see you soon.